In the GINA guidelines, asthma is defined as a heterogeneous disease that is usually characterized by chronic airway inflammation. It is defined by asthma symptoms such as wheeze, shortness of breath, chest tightness, cough that vary over time, and also defined by variable expiratory airflow limitation. So what is severe asthma? Severe asthma is defined by ERS and ATS as asthma that requires treatment with high dose inhaled corticosteroids plus a second controller and or a systemic corticosteroid to prevent it from being uncontrolled, or which remains uncontrolled despite this therapy. So that means that severe asthma can be both controlled and uncontrolled. Also, it's very important that the diagnosis of asthma is correct and that the comorbidities have been addressed and dealt with. Asthma is a rather common disease. It is estimated that around 300 million people worldwide have asthma, and in Denmark that number is 325,000. Based on a Danish registry study, around 8% of asthma patients have severe asthma. The etiology of asthma isn't all that clear. However, we know that there can be genetic predispositions to atopy, but also environmental factors that may increase or reduce the risk of developing asthma. Some of these risk factors are listed below. The pathophysiology of asthma is characterized by certain changes in the mucosa and submucosa. We see infiltration of inflammatory cells, especially eosinophils. We see hyperplasia of mucus glands and mucus plugging in the airways. We see edema of the submucosal tissue, smooth muscle hypertrophia, basement membrane thickening, and also desquamation of the epithelium.
The symptoms of asthma is usually wheezing, coughing, and dyspnea. Mostly the symptoms are intermittent, but in severe cases they can be of a more constant character. The wheezing is usually expiratory. The coughing is most commonly dry, but there can be a little mucus, which is usually clear or light colored. The patients can describe a sensation of breathing through a straw and a feeling of restriction in the respiration with the chest tightness. When treated with bronchodilators, the patient often describe effect of this within a few minutes. Usually the symptoms are triggered by external inhaled agents such as allergens, but it can also be triggered by smoke, perfume, air humidity, and infections, usually virus infections. About 80% of the asthma patients presents exercise-induced symptoms. Regarding clinical and objective findings of asthma, asthma can be difficult to detect in a stable phase, but when patients are symptomatic, sometimes there can be auscultatory wheezing and airway obstruction. Body plethysmography can show a high residual lung volume, and if an HRCT scan is performed, it may show air trapping. Signs of eosinophilic asthma or allergic asthma can be seen in blood samples, where there can be increased blood eosinophils or immunoglobulin E or specific IgE. When diagnosing asthma, some differential diagnoses should be considered, such as COPD, bronchiectasis, and sarcoidosis. Also, interstitial lung diseases should be considered, especially in patients with restrictive lung disease. Also, heart diseases should be considered, including ischemic heart disease and pulmonary embolism. Some patients with a high degree of dyspnea may also have a low VO2 max. In monosymptomatic cough, gastroesophageal reflux disease should be considered, as well as postnasal drip syndrome and eosinophilic bronchitis. If the patient has a relevant smoking history, then malignancy should be considered. In more rare cases, upper respiratory tract obstructions should be considered, such as exercise-induced laryngeal obstruction and vocal cord dysfunction. It is very important to establish an objective diagnosis of asthma, if possible, and there are 4 ways to establish this objective diagnosis: FEV1 reversibility, peak flow variability, FEV1 variability over time, or airway hyperresponsiveness. A reversibility test is a test that measures lung function before and after an intervention. A significant increase in FEV1 is defined as at least 12% and 200 milliliters after administration of a beta-2 agonist or a course of a steroid treatment, either inhaled or oral corticosteroid. If the FEV1 reversibility is more than 400 milliliters and 15%, it increases the positive predictive value of the test. The sensitivity of a reversibility test is quite low, especially if the patients have a normal FEV1. A negative reversibility test thus does not exclude an asthma. Asthma can also be diagnosed through FEV1 variability. This requires a significant variation of FEV1 between 2 visits of at least 200 milliliters and 12%. Using this approach, patients can sometimes be diagnosed retrospectively after starting treatment. Asthma can also be diagnosed through peak flow monitoring. This approach detects variability in the airway caliber. The patient measures 3 peak flows in the evening and in the morning for at least 2 weeks, and the highest value of the 3 is recorded. In untreated or unstable asthma, the morning peak flow is usually significantly lower than the evening peak flow. This can be caused by variation in airway inflammation. A significant peak flow variation is defined of at least 20% and 100 liters per minute. Another diagnostic criteria is diurnal peak flow variation of at least 10%, which is the mean difference between morning and evening peak flow. The sensitivity of peak flow monitoring is only about 30%. And this test usually makes the most sense in patients with night or morning symptoms. The patients should be thoroughly instructed in usage of the peak flow meter. And the interpretation is very important, and outliers should be critically evaluated. A single measurement of peak flow as percent of predicted is not valid for diagnosing asthma because of a wide normal range. Asthma can also be diagnosed through bronchial challenges, of which the mannitol challenge will be described here. The mannitol challenge is an indirect bronchial challenge. The pre-challenge FEV1 must be at least 60% of predicted. And the patients inhale mannitol powder stepwise with increased dosages, and the lung function is measured between each dose. A positive test is at least 15% fall in FEV1 from baseline. If mannitol challenge is used as a diagnostic test, patient must pause ICS at least 6 weeks prior to the test, and leukotriene antagonists at least 72 hours. The mannitol challenge is has a diagnostic sensitivity of 59%, but the specificity is very high, almost 100%. Thus, negative predictor value is 90%, and the mannitol challenge is used primarily as a rule-in test. Hyperresponsiveness to mannitol is associated with type 2 inflammation with high FeNO. Another option for a bronchial challenge is the methacholine challenge. This is a direct bronchial challenge, which induces bronchospasm by direct stimulation of the airway smooth muscles. As in the mannitol test, FEV1 must be at least 60% of predicted, and a positive test is at least 20% decrease in lung function during the test. The methacholine challenge is more sensitive, but less specific than compared with the mannitol challenge. A negative predictive value is 90%, but the positive predictive value is only around 50%, and the methacholine challenge is thus a good choice for ruling out asthma. The methacholine challenge is not associated with an inflammatory profile. Some other bronchial challenges is sometimes applied in the clinic, such as the eucapnic voluntary hyperventilation test, where the patient ventilates with a high respiratory rate in hypercapnic air. Another possibility is the exercise test or an allergen provocation. The measurement of exhaled nitric oxide is very commonly used in the clinic. It is a marker of eosinophilic airway inflammation correlated with epithelial IL-13. If there is a value of 25 parts per billion or lower, then eosinophilic inflammation is unlikely. If it is 25 to 50 parts per billion, then it is possible with eosinophilic inflammation, and if there is more than 50 parts per billion, then it is a probable eosinophilic inflammation in the airways. Patients with high exhaled nitric oxide usually have a favorable response to inhaled corticosteroids, and increasing nitric oxide is also a predictor for asthma exacerbation. In the diagnosis of asthma, exhaled nitric oxide cannot stand alone, but can support the diagnosis. If the patient have allergic rhinitis, then exhaled nitric oxide can be elevated because of this. Exhaled nitric oxide is reduced with about 50% in current smokers. In patients who are incapable of performing a regular spirometry, sometimes impulse oscillometry can be used to diagnose asthma using measurement of airway resistance.
Phenotyping and endotyping asthma patients has become part of the diagnostic workup for patients referred to asthma outpatient clinics. Severe asthma phenotyping is still an evolving field, and consensus on the phenotypes hasn't been reached yet. We phenotype to be able to individualize and target therapy, and assessment of the patient's inflammatory phenotype includes type 2 and non-type 2 asthma. This assessment can help us in selecting the add-on treatment for the patient. Type 2 inflammation is characterized by enhanced activity of interleukin 4, 5 and 13. The type 2 inflammation in asthma, it can be divided into allergic eosinophilic airway inflammation and non-allergic eosinophilic airway inflammation. The non-type 2 inflammation is characterized by enhanced activity of interleukin 8 and 17 and interferon gamma and TNF-alpha. Depending on the cellular findings in sputum, non-type 2 asthma can be further characterized as neutrophilic or paucogranulocytic. When we do inflammatory phenotyping or endotyping, we look at blood samples. We look at the eosinophil count, total IgE, specific IgE for inhaled air allergens. We also do skin prick tests, pheno, and we do induced sputum.
When taking care of patients with asthma in the outpatient setting, the following objective parameters are usually applied: spirometry, exhaled nitric oxide, peak flow monitoring, and bronchial challenges. Also, commonly questionnaires are applied in the clinic, such as the asthma control questionnaire and the asthma control test. The GINA asthma control algorithm can be used to evaluate the current asthma control state. The patients are asked to evaluate whether they have daytime symptoms, night symptoms, need for rescue medication, or a limitation of physical activity. These questions are common for all of the questionnaires used in the clinic. Importantly, patients should get a written action plan, including current medication as well as an instruction for increasing symptoms. Furthermore, an evaluation of adherence and device technique should be performed at every visit.
The cornerstone in asthma treatment is ICS. As soon as the asthma diagnosis is established, an ICS-containing treatment should be initiated. GINA guideline has proposed a stepwise approach to the asthma treatment, with mild and moderate asthma starting at the lower levels. SABAs are short-acting beta-2 agonists. They work by stimulating the beta-2 receptors of the airways and thereby relaxing the airway smooth muscles. They have a rapid onset of action, but the effects also diminishes relatively quickly. ICS is inhaled corticosteroids. They work by reducing the inflammation and reducing the swelling and mucus production in the airways. LABAs are long-acting beta-2 agonists. They work on the same receptors as the SABAs, and the effects last for 12 to 24 hours. Formoterol has a fast onset of action similar to SABAs, and LABAs are administered once or twice daily. LAMAs are long-acting muscarinic antagonists. They block the bronchoconstriction from muscarinic receptors on smooth muscle cells. The effects from LAMAs last for 12 to 24 hours, and they are administered once or twice daily. Leukotriene antagonists, they work by blocking the effects of leukotrienes. They have an effect on asthma and allergic rhinitis, and they're used as add-on therapy to ICS or ICS-LABA in asthma treatment. And now we have come to the specialist asthma management. We use macrolides for the treatment of severe asthma. Macrolides have both an anti-inflammatory and antimicrobial effect. And in the AMAZE study, we saw that long-term azithromycin reduced the number of asthma exacerbations in both the eosinophilic and the non-eosinophilic asthma group. Other add-on therapy for severe asthma are the biologic treatments. These are antibodies directed at specific interleukins or interleukin receptors or antibodies in the inflammatory cascade. We have these 5 at the moment in Denmark. This is omalizumab, which is an anti-IgE treatment. We have dupilumab, which is anti-IL-4, IL-13 treatment. We have mepolizumab and reslizumab, and they are anti-IL-5 treatments, and benralizumab, which is anti-IL-5 receptor treatment. These biologics, they work by blocking the effects of antibodies or interleukins in the inflammatory cascade. And at the moment we only have biologics for the treatment of type 2 asthma. The Danish criteria for receiving biologic treatments are available at the Danish Society of Respiratory Medicine's homepage and guideline from 2020. To be considered for biologic treatment, the patient must be on high-dose ICS plus a second controller, or on daily OCS at least 50% of the time. Other causes of lack of asthma control have been addressed, and the patients must have had 2 or more exacerbations within the past year, or on daily OCS to remain controlled. And they must meet specific criteria for the specific biologic treatment. The specific criteria for biologic treatment is specific for each drug, and these criteria are listed below. The criteria include allergy for perennial allergen for omalizumab, blood eosinophils and sputoeosinophils above a certain threshold for mepolizumab, reslizumab and benralizumab, and also for dupilumab, or pheno and allergic symptoms for dupilumab. In pharmaceutical studies as well as real-life studies, these biologic treatments for severe asthma has shown reduction in the number of asthma exacerbations, improved asthma control, oral corticosteroid sparing effects, and a limited effect on lung function. The dosing of each biologic treatment is unique, and the dosing of each drug is shown below.
Adherence and inhalator technique. Inadequate adherence to treatment is a very common problem in the asthma patients, and less than 50% of the patients take their medication as they should. It is very important that prescription handouts in the pharmacy are checked for every patient at every visit. Increasing exhaled nitric oxide can be a sign of suboptimal adherence, and patients who forget 1 or 2 daily doses of medication can sometimes switch to a once daily treatment and increase their adherence doing that. Also, the inhalation technique is very important, and health professionals treating asthma patients should have an extensive knowledge of all the prescribed inhalers. Usually the patient's inhalation flow is checked, and the powder require a higher flow than aerosols.
Choice of device. It's important to choose the right device for the right patient, and One aspect to consider is whether to use a powder or aerosol inhaler. The patient's ability to inhale should be checked with a measurement of inspiratory flow, and if this is low, then the patient might be best suited for aerosol inhaler. Aerosols inhaler can sometimes be used with a spacer if there is coordination problems. If there are local adverse effects of inhaled corticosteroids in the mouth or upper airways, then consider to switch to a prodrug like Cyclosonate. Particle size can also be an important consideration, in that extra fine particles may be beneficial in some asthma patients with signs of small airway disease. The patient's economy should be considered also when choosing inhaler. Preferably all inhalers should be of the same type of inhaler, so the patient only takes powders or only takes aerosols.
Chronic rhinosinusitis with nasal polyposis. These conditions are associated with severe asthma and type 2 inflammation. Nasal polyposis should be suspected in patients with impaired smell sensation and nasal blockage. And chronic rhinosinusitis is often characterized by a high degree of nasal secretion or posterior dripping, causing chronic coughing. A CT scan can establish the diagnosis, and some biological asthma agents have shown beneficial effect on chronic rhinosinusitis with nasal polyposis. Otherwise, they can be treated with nasal steroids. Obstructive sleep apnea syndrome is associated with severe asthma, where it is commonly found. Nightly hypoxemia can aggravate the airway inflammation and thus airway remodeling. Obstructive sleep apnea is diagnosed and managed in specialized centers. Bronchiectasis is a common comorbidity in asthma. It is characterized by increased mucus production and recurrent exacerbations. The diagnosis is based on symptoms and HRCT scan. Sometimes low-dose azithromycin can be a treatment option in patients with frequent exacerbations. Dysfunctional breathing is characterized by inappropriate breathing with an increased residual lung volume, and it is found with a very high prevalence among asthma patients compared to the background population. The patients report symptoms such as chest tightness, but also yawning and sighing, especially during talking. The severity of their symptoms usually does not correspond to the measurable asthma parameters, such as lung function, exhaled nitric oxide, and peak flow variation. And when the patients use their asthma medication, the effect is usually very limited. Dysfunctional breathing can be assessed and monitored by the Nijmegen questionnaire, and the treatment is physiotherapy, which is usually quite effective. Asthma and obesity. The obese asthma patients tend to have a higher symptom burden and reduced response to asthma therapy. The patients can show a restrictive pattern in their lung function. and due to compression of the small airways, wheezing can occur in these patients and thus mimicking asthma symptoms, but there is no or little or no effect of at the asthma treatment on these symptoms. Neutrophilic asthma is more common in obese patients, and importantly, a weight loss of just around 5 to 10% have been shown to improve asthma control. Gastroesophageal reflux disease can cause dry or slightly mucoid coughing, and these symptoms should be evaluated at a gastroenterologist. COPD is most present in patients who have a smoking history, and should be considered in the asthma patients where there is a non-reversible airway obstruction. The diagnosis can be established through an HRTT scan of thorax and maybe a measurement of diffusion capacity. Asthma and pregnancy. The most important principle in treating pregnant asthma patients is that best possible asthma control is of utmost importance in order to avoid acute exacerbations and pregnancy complications, including preterm birth. Most ICS/LABA treatments are approved for pregnant women. It is important to distinguish asthma symptoms from natural pregnancy features, including dyspnea, and exacerbations in pregnancy are treated as in non-pregnant patients. Oral corticosteroids is indicated in acute asthma exacerbations in pregnant patients, as the benefits of this treatment outweighs the potential fetal risks. Occupational asthma. Occupational exposures can trigger asthma, but may also aggravate existing asthma. Triggers include allergens such as grain, flour, latex, mold, furs, or unspecific irritants such as chemicals, perfumes, and chlorid fumes. Occupational asthma is commonly found amongst bakers or hairdressers and cleaning staff. There is usually an association between work exposure and severity of symptoms, with a sensation of relieving symptoms during holidays. There is a mandatory reporting of occupational asthma to the authorities, and usually the patient should be referred to an occupational specialist. Asthma exacerbation diagnostics. The patients report a worsening of their asthma symptoms despite use of rescue medication. Most frequently, asthma is triggered by viral infections such as the common cold, but the patient's usual triggers as well as inadequate adherence to controller therapy and smoking should be considered. The following examinations should be performed during exacerbation: a peak flow before and after initial treatment, a bedside spirometry if possible, arterial blood gas analysis, chest x-ray, electrocardiogram, blood samples with infection parameters and hematology, including blood eosinophils, a sputum culture, and a swab for viral infection. Peak flow should be repeated during the acute phase, and differential diagnoses such as COPD, pulmonary embolism, heart diseases, and pneumothorax should be considered. Asthma exacerbations are divided into 4 categories depending on severity. There is light, and then there is moderate, which is characterized by peak flow of between 50 and 75% of personal best. A severe asthma exacerbation is defined as peak flow between 33 and 50% of personal best. Tachypnea of at least 30 per minute, or a pulse of 120 per minute, or dyspnea during talking. A life-threatening asthma is defined as severe, but at least with one of the following: altered consciousness, respiratory exhaustion, cardiac arrhythmia, hypertension, cyanosis, silent chest, peak flow of less than 33% of personal best, saturation of less than 92%, or a partial pressure of oxygen of less than 8 kilopascal, or absence of hyperventilation, or hypocapnia, or hypercapnia with an elevated PCO2. If one of the following criteria is present, then intensive care unit should be contacted. Peak flow or FEV1 of less than 50% of personal best despite treatment, persisting hypoxemia, hypercapnia, respiratory acidosis, respiratory exhaustion, change in consciousness, a respiratory rate of more than 30 per minute, incapable of finishing a sentence, a heart rate of more than 120 per minute, or presence of silent chest. Asthma exacerbations are treated with a course of systemic corticosteroid, of which the first dosage can be IV. The dosage is 37.5 to 50 milligrams once daily for 5 to 10 days. The patient should be treated with nebulized bronchodilators with inhaled beta-2 agonists and anticholinergic agents for every 15 minutes during the acute phase, supplementary oxygen as needed, and antibiotics as needed. Magnesium sulfate can be used for very severe cases, usually in intensive care units. When evaluating when to discharge an asthma patient, the following criteria should be used. There should be general clinical improvement, no nightly awakenings during the previous night, no need for acute medicine in nebulized form during the last 24 hours. Peak flow should be at least 60% of personal best. Triggering factors of the exacerbation should be addressed, and patients should be prescribed ICS-containing maintenance therapy at discharge. A plan for worsening or relapse should be provided, and a device inhaler technique check should be performed. Outpatient follow-up should also be planned.